my pleasure and honor to introduce Professor Dr. Gausal A. He is the Green Chief CM, Department of Clinical Nutrition from King Faisal University. And we invite you to follow the live presentation titled Extracellular RNA TLR3 axis in hypoxia, induced myocardial injury, a potential therapeutic target.
Today, I am going to talk about one of the continued research, whatever we are continuing more than 2 decades. And it is one of the important research is called the extracellular RNA TLR3 axis in hypoxia-induced myocardial injury and its potential target implications. As we know, hypoxia is a common state, mainly the deficiency of the oxygens. It could be environmental, it could be systemic, it could be localized oxygen deficiency, oxygen supply. So this state is called the hypoxemia, which where is a low arterial oxygen supply lead to hypoxia tissue and leading to various organ damage and activation of coagulation systems. We have already been published several papers. So here we are going to talk about the little bit new concept. So hypoxia also leading to myocardial injury and myocardial infarction. So we are going to talk about a sterile inflammation. It is a kind of inflammation. It is a non-pathogen induced. That means no bacteria, no virus induced inflammation. So in our body, in the system, there's inflammation due to stress, or it could be hypoxic stress, heat stress, any kind of stress. It leading to inflammation, and this inflammation leading to release of several damage-associated molecular patterns. It's called the DAMPs, like HMGB1, heat shock proteins, S100B, then RNA, DNA, and uric acid. So these are the several molecules that release from the cells. These are called the sterile inflammatory molecules, and it is been all well established. These are going to activate the innate immune system, which is called toll-like receptor. And earlier we already showed sterile inflammation leading to thrombosis, and also induced the insulin resistance. But here we are going to talk about the myocardial injury and also MI. So we know the MI, myocardial injury or infarction, and atherosclerosis and other inflammatory ischemia leading to several cardiovascular disease. And it is one of it's called the heart attack, and leading to it's the #1 death in worldwide. So this sudden death due to myocardial tissue damage or myocardial ischemia, and due to mainly the thrombotic occlusion in the coronary vessels. So the diagnostic marker for this one is only troponin, T, as well as the myoglobulin. And so we take this opportunity and we'd like to know where this hypoxia-induced myocardial injury as well as MI. As you know that all the experiment we have done in animal model in a hypoxia chamber, and you can see here, where is the pointer? Okay. Here in the first panel is a time-dependent increase of the extracellular RNA and extracellular DNA. So what is the extracellular DNA and RNA? DNA, RNA are mainly the nuclear material, but this nuclear materials is thrown out from the cells due to stress. When it is coming in the plasma, it will be chopped by DNAs and RNAs, and it is only 20 to 30 nucleotide small sequence. They are the key in activation of the toll-like, the innate immune system. We call also cytoplasmic nucleic acid. We already showed this, extracellular RNA and hypoxia-induced extracellular RNA having the tissue factor expression activation leading to coagulation. So this is the extrinsic mechanism of activation in the system and leading to thrombosis and thrombus formation. This thrombus going to block the coronary artery and leading to MI. Now, the obvious question whether this eRNA under hypoxic condition may or might initiate any myocardial injury. This is a big question. So, to address this question, we use the same animal model and we did a series of experiments. Initially, we try to measure the troponin T. It is one of the prominent marker of the myocardial injury. If you look at there, troponin, expression, time dependently increase and maximum in 12 hours, and it will remain flat up to 7 days in animal model. And similarly, another marker is the myoglobulin, and it is also going to be similar fashion. So it both the marker indicate that yes, hypoxia-induced troponin T and myoglobulin is might be going to happen MI. To address this issue, so we use another strategy. So whether the RNA involved in hypoxia-induced troponin T release, so use the RNase A, and we treated the RNase A in the animal and then exposing the hypoxia. And we found that RNase-induced, RNA exposed animal significantly decrease the troponin T expression here. So this suggests that yes, it is this whatever the troponin T is expression is coming, it is due to the RNA, eRNA activation. Now we use also another few other molecules to rule out whether HMDB1 is another the sterile inflammatory molecules, as well as so here in the pharmacologically when we inject the animal HMDB1 and then difference, and also the FDA it is the inhibitor. So here it suggests that so whatever the troponin T is coming in hypoxia due to exposure of hypoxia is mainly due to the eRNA, not the HMDB1. So next we would like to rule out this eRNA is mediating or signaling through toll-like receptor 2 or 3. So we use two different strategies. One is the TLR3 antibody, as well as the TLR3 knockout model. So in the both cases, the first panel shows that when you are treated the animal with the TLR3 antibody and exposing hypoxia, and see it is completely blocked and troponin T, and then here it's a non-human glue and TLR3 RNA significant decrease, and the other is the silencing model. We silence the and exposing the hypoxia, and we showed that the TLR3 silencing, TLR3 silencing acute hypoxia is significantly reduced. So it suggests that it is only mediated also the TLR3. Now, this is very important. So whether hypoxia-induced eRNA stimulation leading to collagen accumulation and leukocyte infiltration and in the myocytes, cardiomyocytes. So what happens in the cardiomyocytes and in the cells when there is a stiffness, and it is due to overexpression of the collagen accumulation, and this is mainly due to the leukocyte infiltration and activation. So here, if you look at, we use the two model. We use here, empty stent, and we measure here the empty stent in bar graph. If you look at here in hypoxia, there is a significant increase of collagen in the myocardial artery, and the polyice is the TLR3 inducer, and also RNase A when the animal treated to RNase A, and we declared the RNA and acute significantly decrease here, and RNA itself. If you look at the bar graph, it significantly decreased with the RNase A and acute hypoxia. This suggests that. So, myocardial artery is really, it is a smooth muscle cells. It has a flexibility and elasticity. When the accumulation of the collagen increase, it leading to diminish the Wilkinson effect. So that means, the coronary artery itself couldn't supply the blood. So it leading to, again, the hypoxia. We also, empty stent we use, and we use, alpha smooth, SMA, and also PCAM. PCAM and is the marker of the adhesion marker, and also the, myofibril, this, SMA, alpha SMA. In both cases, you could see here hypoxia-induced ER and facile leukocyte infiltration and activation of cardiomyocytes. Here, if you look at the poly-IC, RNA is decreased, and it's significantly decreased in the smooth muscle cells, alpha smooth muscles, expression, and as well as the PCAM. Actually, PCAM is the adhesion molecule, so it is a significant decrease. So, and also here another panel, we'd like to see the neutrophil elastase. So neutrophil elastase is the marker of the neutrophil. So here in the hypoxia there is a significant increased infiltration of neutrophil and platelets, as well as the megakaryocyte, macrophage, but pre-treatment RNA is significantly decreased. So it suggests that hypoxia-induced ERNA facilitate the infiltration of the CD41 neutrophil, as well as the some other megakaryocytes. And the same here, we also did the immunofluorescence studies. Here we did the CD11 and CD18 macrophage, and we did the same strategy, and we found that hypoxia-induced macrophage infiltration, and when we treat it with the RNase A, and it significantly decreased. So it suggests that. So hypoxia-induced infiltration of all the adhesive molecules are leading to modify the cardiac myocytes. So whether it could be having a role, the troponin release, how troponin is released in the myocardial cells. So it could be the programmed cell death. So we have measured the caspase-3. If you look at here, we use the both model, the eRNA, as well as the pharmacological approach, as well as the genetic approach. In both approach, the first panel is a genetic approach. We silenced the TLR3, and we use and we measured the TLR, caspase-3. Caspase-3 significant decrease, and the similar thing happened in the pharmacological approach when we use the TLR3, neutralizing antibodies and eRNA. And in this data is clearly showed that yes, if you use the RNase A, it could potentially inhibit the caspase-3. So caspase-3 is the mechanism of necrosis and cell death, leading to myocardial injury and stiffness and collapse of the heart. So altogether, it suggests that hypoxia-induced myocardial injury in a time-dependent manner, and eRNA is the main contributor in the hypoxia-induced troponin release rather than the HMGB1 and eDNA. And hypoxia-induced eRNA also, this is facilitate the troponin release through the TLR3 signaling mechanism. So, and it also, eRNA also induce the accumulation of leukocyte infiltration and activation of cardiomyocytes. So hypoxia-induced troponin T release is mediated also through the caspase-3 mechanism. So here, the conclusion is, hypoxia-induced eRNA is subsequently activated TLR3 and leading to all these immune cells accumulation in the myocytes, cardiomyocytes, as well as infiltration of the all the like macrophage, leukocytes, neutrophils, and it's also induced through TLR3 ART and AP1 pathway. So this result, but when you use the RNase A, that means pre-treatment of RNase A could serve as a potential therapeutic option to amyloid disorder, but it needs several more experiments and also a lot of more research to to prove finally this pathway. I would like to thank my student, those who work this project, Dr. Soumya Bhagat. She is right now the postdoctoral fellow in the Washington University in St. Louis, and also Indrani Vishwas. He is also the staff scientist in Oklahoma Medical Research Foundation, Oklahoma, United States, and the funding of Grand Challenge Canada. And I thank you very much, all of the people, those are listening to our work. Thank you very much for your kind attention.